We are lucky to have a FuelIn athlete, but also a cardiologist on tonight. So Ambar, thank you so much for joining us tonight. So I know you're in Minneapolis, married, father of 3. So you know that lifestyle. You have young kids, 11, 9, 5, I think. You know this endurance lifestyle. You've done, marathon athlete. So welcome to the group. We're lucky to have you tonight.
Oh, thanks so much for having me. Yeah, the community's great and your education's fantastic. So I look forward to learning a little bit too and answering whatever questions I can.
Fantastic. So you've been a cardiologist for over 10 years. So you know this is your area of expertise. You know the heart.
It sure is. It sure is. Yeah, absolutely. I love what I do, and it's always fun to talk with people about preventing heart disease rather than trying to clean up the mess after it's already happened. So
I'm sure. Well, all right. We will be picking your brain. We have a bunch of questions. Before we get started in this, though, I want to do a little medical disclaimer for everybody. We are providing education. This is not in lieu of actually speaking with your doctor or physician. While we have a cardiologist on, this is still something that if you have a medical condition or if you're actually looking for medical advice, be sure and see your healthcare professional. Take this information to them, start a conversation. That's really what we're here for. All right, so tonight, the big key topics, we're going to discuss why heart health is important, how to check on your heart health, what tests and screenings you might want to consider, kind of foods and supplements for your heart health. There's a lot of, go into any supplement health food store, you're going to see a lot of things that specifically targeted at heart health. So we're going to work through some of those myths and then some practical takeaways. What, at the end of the day, what really matters. If you guys could have your thing on mute while we're doing this, and then unmute when we have time for questions. You can always post questions down in the chat as well. Jonathan and I will make sure to read and get to those. All right, so importance of heart health. I think it's something that we take for granted as endurance athletes. Like we assume that because we are training at least once a day, sometimes twice a day, 6-7 days a week, that we are in peak physical condition, that our hearts are just always going to be there working for us. As you know, Tim O'Donnell, his episode, which we're going to get into some really specific details about later, you can be the most in shape, fit athlete, and still have issues with your heart and still not know what's going on. So the reason that we want to focus on heart health is not just for longevity and the importance of keeping you alive. Strong hearts equal strong athlete. Your heart is what transports nutrients, oxygen. The stronger that your heart is, the better your VO2 is, which, as we all know, is kind of the performance indicator for endurance athletes, something that we're all trying to improve. And heart disease is the leading cause of death in the United States. And whilst we athletes might not be the prime component of that, there are definitely, it's something that even if this isn't for us, we know people, friends, family, that we want to make sure that we're best informed and able to discuss a topic that really is a danger to people in the United States and in the world. Like heart disease is a serious killer. So we want to make sure that while we're not always, keen on going to the doctor, we are type A athletes, we assume everything is all right. We really want to get in there and make sure that we're taking care of our heart and understanding how important it is. All right, so some of the mistakes that athletes make, and I'm going to have Ambar weigh in here in a second, but I know when we're thinking about our heart health, I know that just assuming that we're all fine and healthy is good. Ambar, what do you think is something that you wish athletes would realize when it comes to the importance of heart health?
I think you've said it well before, and I think it's important to realize that cardiovascular disease has a lot of different things that go into it. Being sedentary and lack of exercise is definitely a big piece of the puzzle, and there's often a lot of positive downstream effects of that in terms of people who exercise and are active tend to have better cholesterol and better blood sugar and better inflammatory markers, and there's just a number of health benefits that are really positive, but that doesn't mean that it's universally true for every person. So you might have a genetic tendency towards high cholesterol, or you may have smoked earlier in your life, and just because you're exercising a lot now doesn't necessarily mean that you're protected from that. And so I think just realizing that a lot of different things go into heart health, and just being active doesn't necessarily guarantee you that you're going to be a perfect picture of health, and doing a little bit of looking into numbers and things that you and Scott talk about quite a bit is really key to make sure that the thing you're doing and enjoying with exercise is done safely and really does promote longevity and wellness.
Do you think that endurance athletes make good patients?
Um,
I feel like I always want to be tough, and we're highly competitive. So potentially going into our doctor, we might not always, be willing to say, I've been feeling some pain, or I've been feeling weak, or my training, I'm not recovering the way that I used to. So I'm wondering if maybe our pride or ego could get in the way of catching something potentially damaging.
Yeah, I could definitely see that. I mean, to be perfectly honest, the majority of my practice is not athlete focused, so I don't have a ton of athletes in my practice, but I could definitely see that where people feel a little bit immune to cardiovascular disease because of their lifestyle, or we deal with so much pain and training, maybe they shrug off, things that are happening as, just part of, a hard session or something where it could be a sign of trouble. But I can't honestly say from experience, I can count the number of endurance athletes in my practice on one hand. So,
which is a good thing in terms of our cohort. We're doing something right.
Absolutely, yeah.
Male versus female, men versus women. I know that the signs and symptoms can be different for heart attacks, for heart disease, for men and women. What do you see? Is it something that is overlooked by one group or another?
So, I mean, as it specifically relates to endurance athletes, and the majority of events seem to happen in men, and I don't know enough about participation, to be honest, whether that's just a fact that there's maybe more men participating in triathlons and marathons, or whether there's just more risk factors in men, but it tends to be a bit more common in men. As far as men versus women, absolutely, women are a little bit less likely to have the typical crushing chest pain, which, when we're talking about cardiovascular disease and endurance athletes, what we're really talking about most of the time is just blockages in heart arteries. There's a number of esoteric rare diseases that young athletes, if you're talking about high school and college age, that you have to worry a bit more about. But if you're talking about what's the typical, Ironman triathlete that's 30, 40, 50, 60 years old, really what we're worried about are heart blockages. So the symptoms of that, more commonly, classically for men, tend to be the elephant on the chest pressure. But even in men, I would say anything that happens above the waist that tends to come on really reliably with activity and then tends to get better pretty quick within minutes when you stop and rest would definitely raise my eyebrows as a potential concern in terms of possible heart blockage. So anything above the waist, it could be neck pain, it could be shoulder pain, it can be elbow pain. It can be any number of different things, but it's just something that doesn't feel very good. It definitely gets worse when you're active, and then it gets better within a few minutes when you stop. And that applies to men and women both.
See, that's fascinating to me too, I think really important and nice to have that delineation, like above the waist, something potentially could be going wrong. And, we all think of the chest pain, but I wouldn't think of elbow pain or, neck, just kind of some of those outlining things. And then too, if it went away quickly, I would be more likely to brush it off. thinking like, oh, it just must have been in that session, no big deal.
Yeah, I mean, the thing I think an athlete is going to have the most is probably some kind of muscular pain. So a muscular pain is going to tend to linger, might linger for, 15, 30 minutes. It might linger for a few hours, might linger for a few days. That tends not to be cardiac pain. But cardiac pain is going to tend to be anything, again, that tends to get better within a few minutes when you stop.
And is it something cumulative that might be a smaller pain?
And a FuelIn?
A smaller pain coming in and then something that grows, or would it just consistently be bothering us?
It could be either, to be perfectly honest. I mean, it could start off as something that just happens at the end of a really long run, or something that happens, just at the very peak of a really high intensity session, but then just starts to come on a little bit earlier and sooner in a session. But it definitely, it can have different presentations.
Okay, so
oh, sorry, good. Sorry, I wanted to ask a question as well. Sorry.
Yeah, please do. Hey, Scott, please do.
No, keep going. I'll ask when you finish.
So I was just going to say, so some of these big mistakes that we're making is obviously not going in to see our physician, kind of that deferred care and maintenance, and then blowing past those warning signs, making it, experiencing some of that and not paying attention to it, maybe not tracking or recording it or actually doing something about it, and then thinking, oh, it went away. I'm an in shape athlete. My fitness is good. It's no big deal. Just kind of summarizing.
Yeah, I mean, yeah, I think it all starts with getting your numbers first, though. So somebody whose cholesterol's high, who's a borderline diabetic, who used to smoke, who's got a family history, you're going to think about something above the waist that comes on with activity and goes away with rest. You're going to think about that very differently in that person versus somebody who's got a perfect cholesterol and a great blood sugar and doesn't have any family history like that. Just your likelihood of disease is so different in those two people. So I think it starts with getting an assessment, a clear picture of where you are, and doing that somewhat regularly. And then, that's going to help guide you a little bit. So I don't want to make everyone think that every time they feel something above the waist when they're running. I mean, we all have, a tough session where you're just, you got a little burning in your lungs, or maybe you got a little tight.
You'll see a lot more athletes, Amber.
we're gonna fill your.
I don't want to over exaggerate that, but the key thing then again is just it starts with that initial assessment, which is the medical term for that is what's your pre-test probability for having heart disease, and once you have that, if you start noticing something, especially if it's coming on if a lot of you are triathletes, if you're noticing something in different modalities where your movements and your muscle pattern, your muscle activation is different, then that would get my attention a lot more than, boy, I can fly in the pool, but then every time I'm on my bike, I feel something in my back. That might be more muscular. But if every time I really hit that high intensity on the bike or on the run or when I'm swimming, then that would be a little bit more concerning.
Yeah. And perfect segue into tests. You started mentioning like screenings and things that we need to get. So we have some laid out, going to see your doctor, first of all, having that discussion, looking at your family health history, if it's not something that you've touched on before, knowing what the risk factors are. Like you said, cholesterol, pre-diabetes type 2, the high glucose, being overweight, having either smoking or having been a smoker, but then the blood test panel too, right? Really dialing in. So can we talk about a few of those kind of markers that you're looking for?
Yeah, absolutely. I know Scott looks like you just sent in a question. Do you want to ask that first?
Yeah, what I wanted to just, before we get into this, because I think what we discussed then in the athlete mistakes is it has to be symptomatic before thinking about seeing a cardiologist. And I think, like to your point, Amber, what you're saying, and just like it shouldn't be wait until you've got something going wrong with you until you actually consider seeing a cardiologist. And this comes down to the non-symptomatic reasons for seeing, which comes into what we're talking about here, is actually being much like we talk about with nutrition. Like, let's establish some baselines. Like if you haven't seen your doctor and for sure, like whether it starts with your GP or going straight to a cardiologist, there'd probably be a referral process, much like there is in Australia. And I'm sure we're going to talk about this, but if you've got a family history, and as you're going to probably talk about, Amber, is, and you've got some of these markers, whether you're hypertensive, so increased blood pressure at rest, your cholesterol markers, your LDLs above a certain level, your fasting glucose, your HbA1c, and so on. And we've got these markers, like, they're not going to know that, are they, until they actually go and get checked. And I think that's probably another, it's not just an athlete mistake. It's an everybody mistake, in that they think they're bulletproof until they're not bulletproof. And actually, that major episode could have been avoided simply by seeing your GP and actually checking the risk factors, and then potentially being referred to someone like Amber, a cardiologist, to actually do more thorough investigation. And I'm sure you're going to get into that, but I just wanted to say, it's not always a symptomatic thing, is it, that we should be waiting for?
Yeah, 100%. Right. It definitely starts with just an awareness of where you're at the outset.
So on that awareness,
Kelly, by the way he looks.
When someone comes into you, is coming into you, what do you want to be able to see so that you have the most information available? Like that full blood panel, obviously cholesterol. Maybe we could talk a little bit about that. I know Scott and I have spent a lot of time on it, but it is, one of those important markers for heart health.
Yeah, absolutely. You want to start with the basics. So, from a historical standpoint, your family history, particularly first degree families, mom, dad, brothers, sisters, anyone who's had a heart disease, but certainly anyone who's had heart disease at an age younger than 70, that would definitely get my attention as a potential risk factor. Now, that also, you have to know some details. If somebody's diabetic or a heavy smoker, that's a little bit different. But in general, family history is a big part of your risk. And then starting off with a good blood pressure, absolutely. So, blood pressure damages the blood vessels. It makes it easier for plaque to deposit and form in the artery. So, checking your blood pressure at rest is really important. And then the basic things that most GPs—
Amber, sorry, what's your diastolic and systolic sort of markers where you consider hypertensive, just so people have an understanding of what that would look like?
So ideal, blood pressure, the one that confers the lowest risk for cardiovascular events, is less than 120 on the systolic and less than 80 on the diastolic. And the risk for cardiovascular events starts to trend up beginning there. The data for any intervention when you're in the 120s or the 80s in terms of systolic and diastolic blood pressure, high and low blood pressure, is pretty soft. The risk there just isn't high enough to warrant really aggressive treatment with medications, but you absolutely want to start paying a little bit of attention to your lifestyle. So for an athlete, that's going to be things like really thinking about how much sodium you're getting in your diet. And then probably alcohol would be the other one I'd think long and hard about in an endurance athlete that might be raising their blood pressure a little bit. And then once you start getting into the 130s, depending on other risk factors like diabetes, blood sugar, family history, then you at least start thinking about if lifestyle is as optimized as you can get it, whether or not somebody needs treatment. But I think you'd be hesitant to do that in an endurance athlete because of the desire to perform, obviously.
So you kind of mentioned like lifestyle factors. I think a tendency we have as athletes is like, well, I'm working hard, I can enjoy myself a little bit. Like, oh, I sweat out some sodium and I work really hard so I can have some alcohol. If my blood pressure is high, or even if I have that family history, there are those lifestyle factors that even if I'm exercising regularly, that can make a difference.
Yeah, I hesitate to, I guess this would speak to your and Scott's approach where you're doing, sweat testing and things like that. There's obviously a place and a role for sodium in all of our lives. But if you're really cavalier about your diet and you're just, eating out twice a day, or you're eating a lot of processed carbohydrates that are rich in sodium, then that could potentially be an intervention. So again, it just goes back a little bit to your and Scott's philosophy about just kind of tracking, knowing your numbers, both your health numbers, but also your sodium intake, your sweat rate, the type of exercise you're doing. So I wouldn't necessarily, say the usual kind of recommendations for hypertensive patients, which is less than 2.5 to 3 grams a day at a minimum, is really applicable to endurance athletes. Certainly not every day of the year for sure.
Okay.
But yeah, sodium, sleep, alcohol, those would probably be the 3 things I would think about, just knowing myself and knowing most endurance athletes. Those might be the 3 opportunities you'd look at, or areas you'd look at if your blood pressure wasn't ideal.
Amber, I have read some stuff about like a sodium intolerance and something where some individuals are more predisposed to an intolerance to sodium and that it can cause increases in blood pressure. Do you have any thoughts around that? Because I have read that sodium intake doesn't necessarily affect everyone in the same way.
Yeah, that's absolutely true. Like we know here in the United States, African Americans tend to be much more susceptible to the effects of sodium on blood pressure. I'm not aware of any really easy, reliable way to know other than trial and error. If you're somebody whose blood pressure is very sensitive to sodium, other than restricting it very sharply and seeing if you get significant changes in your blood pressure. But I'm not aware of an easy lab test like checking urinary sodium or anything like that that would really help delineate that. But there is some variation there for sure.
That's good to know.
And some of the others, glucose, obviously, but can you explain maybe like omega index, kind of the 6-3, like LP, like some of the other components that aren't as mainstream, but yet are
yeah, absolutely. So in terms of lab tests, blood sugar and a conventional cholesterol panel, I think are kind of basic things that obviously any general practitioner or cardiologist would do. And the 2 things you really want to look at in a typical conventional cholesterol panel are the LDL concentration and your non-HDL concentration. So we've really kind of gone away from the idea that a HDL is protective per se. I think that's still something that people think about, and they assume if they have a high HDL that somehow confers protection from a high LDL. And unfortunately, that really hasn't been borne out. So those are the 2 numbers you really want to look at. And in terms of targets, it's hard to just give general numbers there for where a person should be, because it does depend a little bit on their other risk factors. But in general, if you have an LDL above 190, that really sets off alarm bells. That implies somebody who's tends to have a genetic abnormality in how they're processing their cholesterol and puts them at higher risk. So that's definitely something, if you've ever had a number in that range, you definitely want to get checked out. Beyond that,
what does that translate to, Amber, in millimoles? We're used to working in Southern Hemisphere. It's like, I think it's like 3.5 or something like that. Would that be right? Or am I thinking that?
No,
what are you measuring in? You're measuring in what?
We're milligrams per deciliter. So
milligrams per deciliter.
I'd have to,
right.
I could look that up and send it to you, but yeah, I'm sorry. I wasn't prepared for the rest of the world.
One of the drawbacks of living in Southern Hemisphere.
No, I think, that's just unique to America, obviously. But I can definitely send you those numbers or look it up as Elizabeth's going.
That's
on.
great.
But for the American-based athletes, 190 is the number.
Mm-hmm.
The other test I think everyone probably should have at some point in their life is something called a lipoprotein A, which is sort of a genetically inherited form of LDL that's particularly, we think right now, particularly prone to causing plaque formation. So people who have an elevation in their lipoprotein A, irrespective of their other risk factors, tend to have a genetic tendency towards premature cardiovascular disease. So at least once in your life, you should have that checked. And generally, they're a number greater than 90. Again, that's in our units here in the U.S., but that's gonna raise concern. The other thing I think most people should have at least once in their adult life is something called calcium scan. So that's something I'd generally have a low threshold to do. But the key there is how you're going to use it. So calcium scan is kind of a simple CT scan where you're looking for calcium in the heart arteries, and calcium is a key component of plaques. So it's a bit like we think of it like a mammogram of the heart. It tells you, really specifically in that person, is that person depositing plaque in the walls of the heart arteries? You do have to be just a little bit careful how you interpret that, though, because there's a real tendency, I think, if you have any calcium at all, to feel like, do I have a heart blockage? Am I at risk for a heart attack tomorrow? And for 99% of people, that's not the case. So you have to make sure you're doing that with I think, a doctor's consultation and a doctor who's pretty well-versed and comfortable interpreting what calcium scores mean, so that doesn't lead to a lot of anxiety and a lot of unnecessary testing that carries its own risk.
And Amber, would you tend to do, sorry, Elizabeth, would you tend to do the calcium score after, would that tend to be done by the GP or done by, like, would you recommend the GP does that and send them to you, or would you prefer to, say, do an ECG and a stress test, and then if they're potentially asymptomatic, still do a calcium score? Or how would your sort of decision making go with that, or your recommendation?
Yeah, I think that there's a lot of wouldn't say a lot, but there are certainly some GPs that are really comfortable using calcium scoring and interpreting the results. But yeah, I think everyone should have it at least once in their life after the age of 45 or so. I mean, I wouldn't necessarily advocate it for people in their 20s or 30s. It's highly unlikely to be abnormal in that age, but at least once. And if it's zero, then generally we think of that as kind of providing a 5-year sort of warranty for a very low risk of cardiovascular events. So if it's zero, then consider repeating that at about every 5-year intervals.
And what would you consider something where is it over 100 where you start to get concerned? Am I correct in thinking that?
Yeah, so that calcium score is measuring the area and the density of calcium in the heart arteries. So again, it depends a little bit person to person. So in a 70-year-old, your calcium score of 100 is a little bit less important than a score of 100 in a 45-year-old would be quite alarming. So a little bit of it is adjusting for a person's age and their other risk factors. But yeah, often a score of 100 is something we think of now as a good risk marker for when should somebody be on a baby aspirin, or when do we at least start considering cholesterol therapy. But again, there's nuances to that, and you wanna do it under the direction of somebody who's pretty careful interpreting it.
Yep, thank you.
You mentioned earlier that African Americans had a tendency to respond different to sodium. Do we see either genetic differences, male, female, or different ethnicities in any of these tests, like that are more likely to have higher numbers, or something that we should be aware of?
I mean, the other main kind of ethnic group that we worry about for cardiovascular disease are South Asians. So, people like me from the Indian subcontinent. So we tend to have a very abnormal, we often have kind of very abnormal cholesterol profiles and abnormalities and kind of size and density of LDL particles, which are not always captured by the conventional measurements. But beyond that, at least here in the States, we use a database that incorporates kind of Caucasians and African Americans, and we can correct for subtle differences in ethnicities, but I wouldn't say there's big differences in cholesterol or calcium scoring or diabetes that are really independent of lifestyle.
Okay. I want to try to touch on a few more of these and then try to keep us moving here. So you mentioned ECG. I want to look at like a DEXA scan too. For those of us that haven't seen a cardiologist, what is an ECG test, or what?
So an ECG is a basic, basically hooking up 12 electrodes to the body and measuring the electrical signal that comes from the heart. And the electrical activation of the heart can often be abnormal when there's any kind of structural abnormalities with the heart. So it's a really nice screening tool for structural abnormalities, whether that's a disease of the heart muscle or whether that's a prior heart attack. So I think the basic things you'd want to do for just about any athlete are a good history of those basic blood tests. So cholesterol, blood sugar, blood pressure, a lipoprotein A at some point, a calcium scan if you're comfortable using it, and then ECG. And then, the use of stress testing in athletes is a little bit debatable, and you have to be careful with how you interpret that and what you're really looking for with that. So I wouldn't necessarily advocate that every triathlete or every masters athlete go and have a stress test done with their cardiologist or their GP, because if you don't know exactly what you're looking for, stress tests can often be very gray. They're not black and white, and it can lead to a cascade of tests again that at the very least can cause anxiety, but can carry their own risks, in the short term and the long term.
Awesome. All right.
Amber, I've just got one more question. So you mentioned a CT calcium score. At what point in time would you consider doing a CTCA, CT coronary angiogram?
Well, that's a great question. So I think you'd really have to have some risk factors and a positive calcium score before you really consider a CT coronary angiogram. So, if somebody was a smoker, a heavy smoker earlier in life, or if they're a diabetic, if they have that genetic tendency towards very high cholesterol and they have an elevated calcium score, then I'd think about it. There's scenarios actually even with a zero calcium score where you'd think about it, but there would have to be, some remarkable risk factor there, either an extremely high cholesterol or a family history where, family members are having heart disease in their 40s. That's the kind of patient where you want to do that. But again, you have to be really careful with how you do it, because a CT scan is so what Scott's alluding to is a CT scan of the heart arteries. So that's a test where the conventional way, up until 15 years ago that we used to do angiograms, the gold standard for evaluating the heart arteries is to go invasively either into the wrist or the artery that's in the leg with a needle, and then taking a catheter through the body to heart arteries and then putting dye into the arteries. And that's an invasive procedure that carries about a 2 to 3% risk of serious complications. So you don't want to do that without good reason. So CT coronary angiograms have been really a remarkable innovation and are allowing us to see heart arteries directly, non-invasively. But calcium can give you a little bit of what we call blooming artifact. So if you have calcium in the arteries, it can look a little bit worse than it probably is in terms of how much narrowing it's causing. The heart obviously moves all the time, and CT scans are still pictures. So you have to do it really well to get good quality pictures. So sometimes if you're not doing it well, it can raise more questions than it answers. So you have to be really prepared with, this is a person where I'm just looking for high risk disease that's going to cause, the widowmaker, for example. I know that question was brought up with a triathlete that had a heart attack. So you have to say, these are the things I'm really worried about. I'm not going to go chasing, every blurry little artery or every, questionable area. So if somebody's got some really exceptional risk factors, I would consider it. But again, under the care of somebody who's kind of well-versed in the care of athletes and in interpreting those tests. So
since you brought it up, let's do the big Tim O'Donnell question, the widowmaker. Maybe for those that aren't familiar with it, like is it a heart attack? What is it, and why did it potentially happen to Tim?
So the widowmaker is it's a blockage in a particular artery called the left main. So the left main is the main artery that comes down the heart and then splits into two other arteries. So the heart is usually supplied by 3 arteries, but all 3 arteries are not supplying the heart equally. Like depending on each person's anatomy, 1 or 2 of them may be the really dominant important arteries. And the left main is basically supplying 2 of those arteries. So basically, if you have a blockage in the left main, it's like having a severe blockage in 2 out of the 3 major arteries that supply blood to the heart. So it's in popular culture, it's called the widowmaker, because if you have a blockage in that artery, and it causes a heart attack, it can be very difficult to survive an event like that, or come out the other side really in good shape. So in terms of the triathlete in particular, I mean, I think it's hard to say why it would happen to him without knowing a lot of his history. What was his cholesterol? What was his family history? Did he smoke heavily? Does he drink heavily? What was his blood sugar? Without knowing all those kind of things, I think it's really hard to say. But to your point, and the reason for having this session, athletes, just by virtue of being really in good shape and exercising a lot, we're not immune to cardiovascular disease, unfortunately.
Do the symptoms of the widowmaker mimic the traditional symptoms that we know of as a heart attack? Like, do we see it coming on? Is it something that if we're not getting all of this blood work done, that we will know is potentially happening?
Yeah, unfortunately, the symptoms of heart disease, whether it's in the widowmaker or a relatively trivial small artery, tend to be pretty similar. And you wouldn't be able to tell from somebody's symptoms. You really need a stress test or an angiogram or CTCA.
Yeah. And do you see, again, male, female, a tendency for one or the other, more in one or maybe underreported in one group?
In terms of widowmaker?
Yeah. I mean, I know they say the widowmaker, but does it happen in women as well? Like, should we be as concerned?
Oh, absolutely. Yeah. Yeah, I mean, just in general, premenopausal women tend to have lower risk of heart disease just because of some of the hormonal effects of women's hormones on the body and the cholesterol and so forth. So, premenopausal women tend to be protected, but then postmenopausal women, like, we start to think of menopause itself as a risk factor for heart disease. So, it's in general, yes. I mean, premenopausal women tend to be at lower risk for heart disease, but absolutely, all cardiologists have premenopausal women in their practice who, either for genetic reasons or lifestyle reasons, still have very serious heart disease. So,
yeah, thank you. Good. All right, so maybe we can shift now to some potential foods, supplements, and things for heart health. I know, in kind of putting this together, those of you that have been on any of our FuelIn webinars, like this list of healthy foods is not just heart healthy foods. These are things that we recommend on a consistent basis, which is why I like to tell people, healthy food is healthy food, whether it's for your brain, your heart, for performance. These are the things that we should be consuming for a reason. And in this case, they also happen to be very beneficial at keeping our heart healthy. So under, the protein, we've got salmon, we have the small oily fish, chicken breast, lean meats. Under fats, we have eggs, nuts, seeds, olive oil, avocados, carbohydrates, arugula, spinach, oats, chia seeds, pasta, sweet potato, that dark chocolate that everyone loves to see included in there. And then coffee, green tea, black tea. I know that, if I see someone that comes in, if we're looking at an athlete with cholesterol and potentially high A1C, pre-diabetic, obviously these are things that I'm looking at. But do you have, see certain types of diets too that tend to put people more at risk, or that you are quick to recommend these interventions in order to help your patients?
yeah, I think the standard American diet is just rich in really processed foods, processed carbohydrates, and we've kind of gotten away from the notion of good foods and bad foods. It's really patterns of eating, what you and Scott talk about all the time. I mean, a unhealthy pattern of eating with a lot of processed carbohydrates, a lot of processed meats, a lot of sugars, and that's going to elevate your risk for every disease known to man, not just heart disease, but dementia and cancer and autoimmune disease. I mean, it's a common thread for just poor health and poor wellness. So, kind of that, you start with just kind of the basics, sort of the whole food type of eating that you and Scott recommend, and then if somebody's got a genetic tendency towards, a high LDL, for example, that might be a patient where you say, your capacity to eat red meat and still live a really healthy life from a cardiovascular standpoint is probably a bit more limited. So, usually I tell my patients, even some with heart blockages, like, I don't mind you eating a steak once or twice a week if you eat it with a whole pile of vegetables. It's the steak with the French fries or the hamburger with the French fries that I really have a problem with. So, it depends. I think if you once you start deviating from the whole food diet, it depends a little bit on what the person's problem is. So if they're, if they have this really remarkable insulin sensitivity or insulin resistance, obviously you're going to really try to dial back their carbohydrates a little bit and get the carbs from the vegetables like you and Scott talk about. But by and large, for most of us, just most of the time, eating just lots of good, simple, healthy foods, simple meats, all the foods you talked about.
So I know, and I'll let Scott chime in too, when we have our athletes doing some blood labs and we see some of those cholesterol markers and then make some of these dietary interventions, if you will, it's very easy to see a correlation, almost like a correction of course, if they actually start implementing and incorporating more of these types of foods into their diet. Scott, do you think that you see the kind of the same benefit of people taking the time to implement these healthy changes?
Yeah, I think Amber hit the nail on the head actually with and the problem with most nutritional studies is there's so many confounding factors that, people will point the finger at red meat, but it's actually what is being consumed with that red meat that could be the confounding factor that actually then throws it over the cliff. So as he said, eating a bunch of French fries with that steak, of course, that's going to add, a heap of, vegetable oil plus potentially other refined carbohydrates into the mix that, thrown with the saturated fat in the meat is potentially not going to be great. So it's really nice to hear a cardiologist talking very sensibly about that. And I take my hat off to you, Amber, for saying that. I think that and to your point about ultra processed food, I actually just wrote an article about this, but it's a longitudinal study and it's observational, but it's in America and it's from 2001 to 2018. And it was looking at the consumption of ultra processed foods across all age groups from 25, I think, to 75, male and female, and from a range of broad socioeconomic backgrounds. And interestingly, and this was just in America, it's 53% of dietary calories taken in were from what the definition of ultra processed foods. And sadly, over the last, I think 15 or 16 years, that number has now crept up to 59% of total calories being consumed from ultra processed foods. Now, there's a lot of issues with definition there as well, because unfortunately or fortunately, some of these ultra processed foods are now being packaged up as healthy foods. And I think that's where you see this all the time, that these health foods are highly processed yet proposed to have health benefits. And I think you've just got to be so careful with what you're eating and choosing. And to Amber's point, and what we keep banging on about is just choose whole foods first and foremost. And if they don't have we did a video on, reading ingredient labels. And I think the caveat to that is broccoli doesn't have an ingredients label on it. Neither does arugula, either does a piece of salmon or a piece of steak. They just don't have these long ingredient lists. And if you can stick to whole foods, you're probably going to be, you're 90 odd % ahead of the rest of the field in terms of your dietary choice. So that's probably my little rant. But specifically to, you mentioned red meat, which was nice, and I can move past that. Eggs. I think eggs is always one of those topics. Now, Amber, I've read there's conflicting evidence on this, that habitual consumption of eggs, up to 12, 13 in a week has no impact on cholesterol. But what's your take on that? Is that specific to the individual? Is it genetics, do you think? Or
I think it probably is. I mean, the amount of cholesterol that's in your body and the fact that billions of your cells are able to synthesize cholesterol, calls into question just how important it is for most people to really limit something that probably has a lot of health benefits like eggs, just because of the dietary cholesterol. And people do absorb cholesterol from the intestine differently based on genetics, based on the different channels that are activated in that particular individual and the concentration of those channels. So I would say if you've had 3 bypass surgeries, then you're probably not going to want to think about eating a lot of eggs. But if you're an otherwise healthy triathlete and you're just looking for different sources of protein, and again, as long as you stick to that whole food type of mindset, I think you're probably going to be okay. But again, if you decide to put a whole jar of salt on your eggs and then eat it with a bunch of hash browns and wash it down with coffee and cream and
a couple of
then you've got
rashes of
that
bacon.
recipe. That's right. So then you've got the sodium, you've got the saturated fat, you've got the inflammation from all the carbohydrates, and then you start putting enough stuff into the stew that makes up heart disease and all diseases that can be bothersome. But no, absolutely, an egg, as many of your recipes include, with a side of vegetables, I think is fantastic for 99% of people.
And then oh, sorry, yeah.
I was just going to say, I think that's the phrase of the day, like the stew that makes up heart disease. I think if we can take that away, that's just a brilliant way to put all of this information together. It's not just one thing. It's not just one dangerous food or one dangerous lifestyle habit. It's all of these components combined that create the potential for heart disease.
Amber, a question about fats now again. Coconut oil. I think everyone, well, certainly I'll talk personally, probably was sucked in a little bit related to the MCT research and then its relationship to coconut oil. But anecdotally, my experience is that consumption of coconut oil will push up LDLs terribly in most people. And actually, I'm quite an advocate for removing coconut oil from the diet now. What's your take on coconut oil?
Yeah, I mean, I think a cardiologist probably thinks about coconut oil a little bit more simplistically. Absolutely, I mean, it's laden with saturated fat, and saturated fat will definitely elevate your LDL. And I think people who really advocate for that type of diet and lifestyle will say that they'll bring up imperfections with how you measure LDL, which are true, and they'll bring up the fact that the type of LDL that people who eat diets rich in saturated fat have is a little bit less unhealthy than people who have maybe a similar LDL but a typical Western diet where they're eating a lot of processed carbohydrates along with the saturated fat, which may be true. But it's undeniable that heart disease correlates with LDL levels or LDL-like particles. I don't know if you want to get into ApoB or not, but if you have a high LDL, you are at higher risk. It doesn't mean you're at 100% risk, but if you have a higher LDL, which your LDL will almost certainly go up if you significantly increase your intake of saturated fat, then you will be at higher risk for heart disease. There's no question about that.
Yeah, and to that point, Amber, I can tell you now personally, huge difference, and I can actually say it. I get my blood work done quite regularly, and I can pinpoint the point where I started consuming large amounts of coconut oil to the point where I removed it and saw the change in my LDL levels. And I've seen the same with many athletes that I've worked with. And there is that distinction between potentially MCTs and coconut oil and actually breaking down into that MCT. And that's probably a whole nother conversation. But I think for the general, athlete out there, I would just very much caution the consumption of coconut oil, and also looking at all the, random nutritional products you're consuming, because a lot of them will either use vegetable oils or coconut oils as their base oils as well, because they're cheaper. So no, it's nice to hear that. So that's probably all I've got to talk about in that.
For For now, not
For now.
for now. All right, so let's go over, I think, supplements. And I know, Scott, we talk about this, complements, not supplements, but in this case, heart health is definitely a marketable tool, especially for not just athletes, but I think the majority, at least I see, of Americans here, like in all of our big Costco's, there's, you know, the huge size bottles of like heart health pills that are a combination of Lord knows what. We've all heard, you know, do I need to take an aspirin? Do I not? So I tried to break it down into research backed and ones that are definitely more approved, some that have evidence either way, and then some that I would think we should use caution with. So fish oil, vitamin D, and aspirin. How do you feel about those three?
So aspirin, I think, you know, you have to be careful with, and aspirin is not a totally benign drug. It can irritate the lining of the stomach and cause, you know, fairly significant gastrointestinal bleeding in certain patients. So that's an area where a lot of us now are using calcium scanning to help identify patients who really probably would benefit from a baby aspirin, but not universally recommending it anymore at all. So I think for my gestalt that most of your athletes are pretty healthy and younger. I think it's probably few and far between the people who would benefit from a daily aspirin. But yeah, talk to your GP. It's a combination of your risk factors but I wouldn't say a blanket recommendation at all. I think vitamin D and fish oil. There's a lot of good what we call basic science data. So if you look at fish oil, it's found in high concentrations in the brain and in the heart, and there's some, you know, interesting data from populations that eat a lot of fish that they have lower rates of cardiovascular disease. But if you look at the intervention trials, they're actually by and large negative, especially in kind of modern therapy with modern medicine. So I'm kind of lukewarm on fish oil. I mean, I think the chances that it's harming anyone is very low. I certainly can't say that there's any really definitive evidence to suggest that everyone should take fish oil, or everyone that doesn't eat salmon twice a week should take fish oil. But, you know, those studies, you know, it's expensive to do studies, so the people will typically follow patients for 3 years or 5 years. So I don't know, you know, none of us know if you take fish oil for 30 years, that might be, you know, something that on the margins may help you slightly from a cardiovascular disease standpoint. And same thing with vitamin D. I think the intervention trials have been negative, but again, they're somewhat time limited. So, you know, I think, you know, certainly vitamin D levels, I think trying to just keep those in a healthy range, and Scott, you know plenty about that, and probably more than I do, I think makes sense to me. The fish oil question, I think is probably a little bit harder, but I do tend to tell people that don't eat a lot of salmon, it's probably not a bad idea to take, you know, 1 or 2 tablets over the counter, which is going to be, you know, roughly 600 or so grams of EPA and DHA. It's probably not harming you, and it may be helpful in the long run.
Amber, just on that about fish oils, because I think it is really interesting. And again, like nutritional intervention studies are very difficult. Do you, and what again, going back to your Western life, the Western diets, one test that I came across when I was actually up at Toronto and we implemented it was like looking at the omega index and the omega 6:3 ratio. And it was actually, I mean, these guys were professional athletes, and they're, you know, you aim for an index of 8 to 12%. Most of them were in the sort of 4 to 5%, which sort of correlated pretty well with the evidence that I've seen in the research looking at a Western diet, and their 6:3 ratio being somewhere like, you know, a 5 to 1 as opposed to a 1 to 3 ratio. And I was wondering whether you see any value in that type of test. I mean, I personally recommend it, and Elizabeth and the FuelIn team will recommend like getting those 2 omega tests done to quantify what sort of levels the individual would have in terms of their omega sort of position. How do you feel about that?
You know, honestly, I think this is probably an area where you and Elizabeth know the data a lot better than I do. I mean, for us in cardiovascular disease, I'm not aware of any of the big studies that really target populations that have low, you know, omega-3 to omega-6 percentages. And it's not something that I use clinically, to be perfectly honest, but that doesn't mean that it's not a good test for the right patient, or that it might, again, not be advantageous for your athletes over the course of 10 or 15 years.
Yeah,
it's just not something that we're using a lot clinically, but that could be a limitation of our training and our background and lack thereof in nutrition.
Look, I just tend to look at it as part of a piece of puzzle, I guess. You look at that, if that's terrible and they've got high LDL and lower HDL and their total cholesterol is high, it's like, well, everyone tells you to eat fish oils, but you've clearly got, low levels. Let's see if we can boost those up, see what that does, and look at it that way to the individual. And more often than not, it's probably wholesale changes in combination with, I guess, that consumption of fatty acids that potentially makes the difference. And yeah, I guess if it's do no harm, but again, on that, high fish oil consumption can cause harm. Is that correct? Where we tend to recommend around 3,000 milligrams of EPA DHA if you've got blood clotting issues or things like that, that can be potentially dangerous as well.
Is I mean, there's definitely a blood thinning effect. I wouldn't say, I would recommend, if somebody isn't eating salmon, if they're interested. Again, I think it is probably something that's on the margins of good health. I mean, I think if you're optimizing if you're eating a whole food diet and you're doing the activity and the recovery and the your basic things are optimized, like your blood sugar and your cholesterol, and you're not smoking. I suspect these kind of things are probably in that 1 or 2% type of, like, try to get 98% of the basic things right, but that those things on the fringes for the elite athletes or somebody who's really trying to be at the tip of the arrow, so to speak, it might be beneficial, but it's just not a place where I practice. I'm just trying to get people to walk 30 minutes, 6 days a week. That's the win I'm looking for. So I think our clientele is probably different, and I'm just limited in that area, to be perfectly honest.
Yeah,
no, for sure.
So I just want to touch quickly on some of the ones that potentially could be dangerous. I don't know if you see patients coming in that are trying different things. I know red yeast rice was big for a while. I think good old Dr. Oz talked about it or something. And like the magic formula is CoQ10, LRG. Like, do you see any potentially dangerous ones that we should be watching out for, or if we have family members that might be taking these because their doctor told them they had heart health issues?
So red yeast rice, generally has a mechanism similar to the statin type drugs. So the statins are the most common form of cholesterol lowering medication, and they inhibit the cholesterol synthesis inside the body. So the red yeast rice does much the same, but it's over the counter, it's unregulated. And certainly for an endurance athlete, I think you're going to think long and hard about putting them on a statin, which, a significant number of people will have muscular side effects. So I wouldn't recommend that, certainly for your population of athletes and patients. L-arginine is something that is a precursor for nitric oxide. So it can, it's often used medically for people who have problems with their blood vessels dilating. I myself have never encountered a patient who's taking it over the counter on their own. And again, it's just my practice. It doesn't often, so I just don't see it very often to know whether it's something that could be harmful if you did it over the counter. I've never seen a patient do that themselves. So we prescribe it usually. I'm sorry, what was the third one that you had mentioned?
I said CoQ10, but really just in general, like any of the heart health general supplements or anyone that maybe I didn't have on the list that potentially you see people taking that they think may improve health status.
Yeah, I guess my bias would be, for the most part, for most of us, just spend more of our time and energy just trying to build healthy food habits rather than adding a whole bunch of supplements without measuring things. So if you're vitamin D deficient, get some vitamin D. If you're you're not eating salmon, consider fish oil, but to really think again that you're going to make a big difference in your life, or you're going to overcome a lot of bad health habits day to day by taking a supplement just isn't, it's not practical. So yeah, I would say under the guidance of a nutritionist or a physician who's really well versed in these things. Otherwise, I just think, yeah, you're probably wasting a little bit of time and energy and money and places where you're probably not getting that much benefit.
Thank you. Excellent. Say it louder.
Well said, Amber. Well said.
I think I'm borrowing lines from you and you and Elizabeth, to be honest.
Right. So I'm trying to, hey, we're all a team here. As long as we get the message out, it doesn't matter where it comes from. All right. So to kind of wrap things up, I know I want to keep it, everyone has, things to do. So the key takeaways, I think big one from our discussion is just that it is a combination of a lot of different things. And the most important thing is that we are paying attention and get baseline testing done, go see a physician. Don't just assume that because we are endurance athletes and training all the time that we're automatically healthy. And then, so doing your yearly screening, the importance of daily nutrition, whole food nutrition, knowing what the signs and symptoms are for heart disease, heart attack, stroke, understanding your family history, and then obviously for us staying active. Do you think, if I could get this message out to your patients and other cardiologist patients, is this the big message that, do you think it covers enough?
I think so. Yeah. And I guess the one thing I'd add to that is, if you can, I would try to follow with a sports cardiologist. So again, just to kind of the point here at the end of the conversation, like your needs and your bodies are quite different than the usual patient that a GP is seeing and that a cardiologist is seeing. And we didn't touch much on an athlete's heart, but athlete's heart is a term that describes a athlete, much like many of you probably triathletes, and the changes that the heart undergoes to support that level of physical activity can mimic, in a lot of cases, real pathology. And trying to differentiate that and advise people on what to do really requires a nuanced understanding for the most part in how to interpret tests in athletes and how to make recommendations for athletes. So you just be careful. Is not every doctor is really comfortable with athletes and their needs. And like I said, I mean, any test can be interpreted incorrectly and can lead to more tests or more anxiety, and that's not a good thing. So if you have access to it, to a sports cardiologist, I'd highly recommend trying to select that person to do your screening.
Thank you. Yes, a very important, very good takeaway message indeed. Scott, do you have any final thoughts?
No, it's fantastic, Amber. I think it's extremely useful, and hopefully the athletes found it useful. I know it certainly is very confusing as to know when to do it, but hopefully people take from this that it's not until you actually feel something before you should go and see someone and get checked, get some baselines and establish those, and then go from there. So yeah, wonderful that you could join today, Amber. Yeah. Really appreciate your time.
It's really insightful, and
yeah,
it's very comforting to get. I know here, I have Kaiser Healthcare. Like, I have not had this much time with a physician or a cardiologist if you added up all of the years. Like, so your time is so valuable, and I know I really appreciate just getting to ask and kind of pick your brain on all of this. Really fascinating. Thank you.
Oh, that's really kind of you, and I feel the same way about both of you and Jonathan. I mean, the work you do is just fantastic and steeped in good science and great recommendations. So I can only support everything that you guys have said, like I said, in numerous podcasts. So keep up the good work.
Thank you.
Thanks so much, Ambar. All right. Well, thanks, everyone. I know we're over on our time. Thank you for staying a little bit over, and we'll send out the recording. Thanks everyone for joining.
Thanks, guys. We'll see you on the next one.
Thanks, everyone.
Thank you.
Bye-bye.